The idea behind this event is to fill a long-standing historical gap in the history of smallpox eradication. In 1958 and 59, the World Health Assembly, which oversees the work of the World Health Organization, voted for a worldwide smallpox eradication program. Majority of the member states of the World Health Assembly actually voted for this resolution. The idea was proposed by the Soviet Union based on epidemiological data from its own territory, and its representatives noted that they had limited the impact of the disease within the Soviet Union through effective surveillance and vaccination. But as the USSR advocated global smallpox eradication, its Vice Minister for Health, Zhdanov, was also very honest about a weakness in the Soviet program that had caused him to come to the World Health Assembly and recommend global action. Zhdanov mentioned that despite the fact that the Soviet Union had got rid of smallpox on several occasions, there would be reimportations of the disease from surrounding countries like Iran or Afghanistan. So the message he wanted to give the World Health Assembly was that the world needed to work together to make sure that the disease was gone for good. Now, existing historical work is focused primarily on the period from the second half of the 1960s. That is, a period after the United States Centers for Disease Control organized a well-funded vaccination program in 20 countries of Western Africa. And after success was achieved in Western Africa, CDC, the US CDC, got involved in work in South Asia and at the end, Eastern Africa, the Horn of Africa, Somalia, and Ethiopia. Now, this event draws on detailed evidence-based research prepared by 4 scholars to do 2 things. One, to show that the international engagements between 1958 and 68 were rich and important. So, we raise the question here, why has the period between 1958 and 1967, when the call for intensification of the smallpox eradication program began, why has that period been ignored? Secondly, this event draws on 4 very important case studies where significant progress was made in relation to smallpox surveillance, vaccination, to the extent that in a country like China that Lou will talk about, smallpox is actually eliminated from within China by the time intensification begins. You have to remember here it's a country of 1 billion people. And yet, the existing history, institutional history of the WHO, for example, does not really pay due attention to how the successes in China made it easier for international groups of officials to advocate a wider smallpox eradication program. So we'll have colleagues also look at Brazil, India, and Nepal, which is, again, a fascinating case study which the official history of the WHO actually recognizes as being an exception to the rule. So we are delighted to have a speaker focus on that. There can be no doubt that histories of smallpox eradication help us prepare better for international action against infectious disease and promote future vaccination projects and plans at an international level. But I do believe that for such history-led preparation to be effective, it is incumbent on us, professional historians, to prepare a more complex and realistic history that does not exclude the many hundreds of thousands involved in preparing and running national chapters of an international worldwide eradication program. So I'm not going to labor this point further. I'd like to introduce our four speakers to you. We have Chen, who's a member of the Center for Global Health History. She's on a Wellcome Trust PhD studentship. Following Lu will be Dr. Susan Heydon, who's a social pharmacist and historian from the University of Otago in New Zealand, who we are delighted to welcome in York. Then we're going to have Dr. Carlos Campani, who's hiding behind the screen. I've just seen him. And he is currently in the Department of Health Sciences at the University of York and is a clinician by profession and has practiced for many years in Brazil. His case study will be on Brazil. And then we have our own Dr. Namrata Ganneri, who is a Commonwealth Fellow, Commonwealth Rutherford Fellow at the University of York, but is a permanent member of staff in the Department of History in SNDT University in Mumbai, India. And she will be talking to us about relatively ignored aspects of the Indian program. Last but not the least, we have a wonderful colleague from Zimbabwe, an elder from Africa who everyone should listen to, Dr. Godfrey Sikipa, who will comment for about 10 minutes about all these presentations. I mean, Godfrey is one of those elders who has seen these programs in action. And if I might add, I really feel that what we have in relation to the smallpox eradication program in Africa is a US-centered interpretation of what happened in Africa. What is still needed is an Africa-centered understanding of what happened in relation to smallpox eradication across that wondrous, very diverse continent. And I hope Godfrey will be able to fire up some young researchers at his end to follow up this work. So without further ado, Lou, welcome, please.
Thank you. Thank you. Good afternoon, everyone. Thanks for joining us today. And I'm going to share some experience of smallpox eradication in China. And China is a very specific case in worldwide smallpox eradication because the whole program happened before the intensified program started. So in 1949, the Communism Party won the Civil War and built People's Republic of China. And in 1952, China withdrew from the United Nations system and didn't recover its representation until 1971. So during 1949 to 1971, there was no direct information exchange between China and WTO. And however, after World War II, in 1950s, smallpox was highly endemic in China. So we can see this map on the left hand. There were more than 50,000 cases in China in 1950, and compared to the other countries, although there were less cases than India, but there were more cases probably than Nepal and Brazil. And there were also other communicable diseases in China in the 1950s, although smallpox was not the most prevalent communicable disease, but it was one of the most fatal communicable disease. So the fatality rate could reach almost 20% from this chart. And the smallpox eradication in China actually started from 1950, when the Prime Minister announced a decision that to carry out a mass smallpox vaccination program for the whole population of mainland China. And there were 3 rounds of mass vaccination in total. So the first round of mass vaccination was from 1950 to 1953. And the smallpox had been eradicated in eastern coast areas, like eastern coast areas in here. And we can see smallpox had been eradicated in big cities like Beijing, Tianjin, and Shanghai. For the other areas, smallpox epidemic had been reduced to a very low level. And the second round of mass vaccination was from 1950 to 1958. And smallpox had been eradicated in the northeastern China or northwestern China, most of the areas. And the third round of mass vaccination came in 1960. And because there were an outbreak in Yunnan province, and those cases were believed to be introduced from India, Nepal here, and also Burma. So the border areas were given the first priority. And after this round, smallpox had been eradicated in Yunnan province. And this was believed to be the last case and was written in a report submitted to the WHO in 1979. But after the certification, the Chinese government found there was another round of outbreak in Shanxi and Inner Mongolia. So those cases were caused by human inoculation materials. So there was actually another round of outbreak from 1964 to 1965. But the last case was in 1965. So except for the mass vaccination, there was also the regular vaccination program. So in 1950, the Ministry of Health ruled that all children should be vaccinated within 6 months after birth and revaccinated every 6 years after they are born until they are 18 years old. And in 1953, China also built an epidemic prevention system. And for the smallpox surveillance, it's also very important. In 1955, the rule that smallpox or suspected cases should be reported within 6 hours in urban areas and within 12 hours in rural areas. So because of those mass vaccination, regular vaccination, and the surveillance system, smallpox was eradicated in China in 1955. But however, during 1950s and 60s, the situation in China was deficiency of food supply and very low economic growth. So we can see from this chart that it shows daily per capita supply of calories. And the yellow line represents China, and we can see in 1959 there's a great drop down. It's because of the Great Famine in China. And the food supply level in China in 1960s, it was lower than India. And also the economic growth was in a similar level. This is the GDP per capita, shows different countries, and the green line represents China. So the GDP in China, at least in 1960s, it was in the similar level with India and Nepal. So the question is, how did China reach the smallpox eradication independently under the circumstances of deficiency of food supply and low economic growth? And there were several factors I would to highlight. So I think the first reason was the political reason, and there were technical factors and social historical factors, and finally was social mobilization. So first one, I think it comes from the Chinese government commitment on improving public health in general. So smallpox eradication was not an isolated program in China. It was integrated into an overall national health movement against all major endemic and epidemic diseases. So it was called Patriotic Health Campaign. The Patriotic Health Campaign aimed to improve health for socialism constructions. So except for smallpox, there were other diseases were targeted for elimination or eradication as well. For example, the schistosomiasis and tuberculosis and malaria. And also the government was aimed to improve the environmental health as well. So from Mao's speech in 1956, so we can see the leaders in China all consider the disease and poor sanitation as an enemy of the progress toward modernity and build the new socialism country. Therefore, the government committed to improve public health in general, although this purpose was very highly political and ideological. Okay. The second important reason was the independent ability of manufacturing smallpox vaccines. Actually, before 1949, China started to do research on smallpox vaccines since 1912. So the first research institute, smallpox vaccine research institute, was built in 1912. And in 1926, Chinese scientists developed a vaccinia strain called Temple of Heaven strain, and it was used in the later manufacturing of smallpox vaccines. So after 1949, the government took over those vaccine research and manufacture institutes. So in 1950s, there were five big manufacture centers in China, and there were in Beijing here, and Dalian here, and Shanghai, and Lanzhou, and here in Kunming. So those manufacturer centers cover different areas in China. So the vaccines didn't have to be shipped for a long distance. And during the second round of mass vaccination, they also developed a freeze-dried vaccine as well. So those vaccine-producing centers, they manufacture a large amount of vaccines during 1950s to 60s. So here is the chart shows how many doses had been issued during 1950s to 60s. So in 1952, there were nearly 300 million doses of vaccine had been issued, which covered nearly 46% of the population. Okay, so the third important factor was social historical factor, because smallpox vaccination was highly accepted among Chinese people. In ancient China, people started to use human inoculation to prevent smallpox. So during 18th and 19th centuries, smallpox vaccination had already been highly accepted along Yangtze River here, and also the eastern coastal areas. So after Ganneri vaccination introduced to China in 18th century, each government had organized a vaccination program. So before, so actually when it started in 1950s and 60s, and smallpox vaccination had already been accepted by the majority of people. Although there were some resistance was reported in Yunnan province here and border areas where minority groups lived. So the last factor was social mobilization. And because this is a very huge program, has the whole population participated, and how to convince people to get vaccinated is an interesting thing. And the first thing was to connect those hatred and fear towards enemies with disease. In 1952, the Chinese government accused the United States military used biological weapons during Korean War. Although this validity of the accusation was not clear, but Chinese government used the germ warfare to push political reform in China and launched the Patriotic House campaign. So like the posters here during Patriotic House campaign, it said resolutely cut off the bloody and criminal hand of American aggressors that spread germs. So they delivered a both message that China was threatened by American aggression and by natural bacteria, so it was very important for Chinese people to fight against both enemies. So the hatred emotions toward enemies and disease provoked people's enthusiasm to participate in those vaccination programs. Okay, so the second thing for social mobilization is to transfer the expert knowledge to general public, because in 1950s and 60s, the illiteracy rate in China was very high. So in 1949, the illiteracy rate was 80%, and in 1964, there were still more than half the people who couldn't read. So how to teach them those knowledge about smallpox and vaccination? And the first thing is during the mass vaccination program, the local government would usually organize some training sessions here and to teach people about the smallpox and the vaccines. And they will also use radio broadcast to broadcast the knowledge. And some local cadres and leaders will go to people's house to do persuasion, to do peer pressure persuasion, persuade people get vaccinated. And they will also use some other art performance, like traditional folk art, and to performance the smallpox and the vaccination. And the local government would also print those posters, and education fleet or publish some cosmic books about smallpox and prevention. So, for example, a poster like this, it tells people everybody should get vaccinated and prevent smallpox. And on the top left corner, it shows the symptoms and the consequence of smallpox. And on the top right corner, it shows what should you do after there was smallpox cases. First, you have to report and then isolate the patient, and then get vaccinated, and then sterilize the patient's house. And on the right, left bottom corner, it said how smallpox was transmitted by direct contact the patient or by using the belongings patients has used. So on the right and left hand said, completely defeat American imperialism's germ warfare, and everybody should participate in the patriotic health campaigns. So those pictures are very clear to show the knowledge about smallpox, and also use a format people could understand. And another important thing was the vaccinators. And because in 1950s and 60s, there was not enough medical professionals in China. So lots of vaccinators was selected among people. For example, the local cadres, local leaders, or school teachers, or some medical school students. They were selected to give some short-term trainings to teach them how to use the multipuncture vaccination to vaccinate people. Because those vaccinators will actually confirm people, and they're already familiar and trust, so it's easier for people to get vaccinated. Okay, so all of those achievements had not been acknowledged by the WHO until late 1970s. So although the WHO tried to get information when the global program launched in 1967, but nothing had been learned. And in 1977, when the last case appeared in Somalia, the WHO started to increase its communication with Chinese government regarding about the certification, because China was a very big country, has a billion population. However, in the first place, the Chinese government was very reluctant to cooperate, so they spent 2 years to negotiate with each other. And finally, in 1979, China was agreed to be certified by the WHO, and agreed to be visited by a global commission team, and also submit a country report. So the case in China, WHO actually had a very limited role and very limited impact. So the smallpox eradication in China was placed into the existing public health structures and adapted to the local political, social, geographical, cultural, and epidemiological realities. So those people who contributed most to the smallpox eradication in China were the national and regional health officials, scientists who did research on the smallpox vaccines, and also those local health workers and vaccinators. So I think it's important to learn the experience in the early stage in 1950s and 60s, and to learn the experience from those people whose names haven't been known, and whose stories haven't been told, and whose voices haven't been heard. And this is all I want to share. Thank you very much for listening.
Thank you. I think we've seen the vast scale of the Chinese contribution. I think my presentation is very much about a small program. Sandwiched between the regional powers of India and China is the small Himalayan nation state of Nepal. And its buffer status has been a key feature of its external relations. The mountains in the picture here are part of the northern border with the Tibet Autonomous Region of China. In those previous slides, some of those, Nepal was the little blank bit in the middle of a sea of information. We know very little about what happened in Nepal in this early period. Nepal, with a population of 9 to 10 million, was one of the last group of countries in the world to eradicate the disease. Now, if the eradication program was about vaccination, surveillance, and containment, we should not forget that Nepalese people's experiences were also of a common and dreadful disease looked after mainly at home. The World Health Assembly goal was worldwide eradication, and so programs in small countries matter and need to be part of the historiography. WHO Project Nepal 9 refers to the WHO assisted smallpox program that operated throughout the worldwide eradication program, from its introduction in early 1962, first as the Smallpox Control Pilot Project in the Kathmandu Valley, before becoming a smallpox eradication program that was then gradually expanded throughout the country. From the perspective of the Nepalese government in the capital Kathmandu, smallpox was part of the wider context of communicable disease control. Other diseases were bigger problems. In the monumental official history of the eradication program, which for Nepal is the only published account, Nepal, in 9 pages, was presented as, quote, an epidemiological extension of the Indian states of Bihar and Uttar Pradesh, which it bordered to the south. Hence my picture of the mountains to the north to rather contradict that image. The pilot project was dismissed as, quote, poorly funded, poorly supervised, and poorly executed. Everything that mattered in terms of the eradication program occurred after the introduction of the intensified program beginning in 1968, and particularly after 1971. Nepal, however, adopted a novel strategy of mass vaccination for 1 month annually to support the surveillance and containment activities. Comments from WHO HQ went from despair to praise. Nepal was no longer classified as an endemic country in 1973. Its last case of smallpox was in 1975, and the disease was declared eradicated in 1977. So even in the official history, Nepal was regarded as exceptional. Today, however, I don't want to talk about these later stages, but instead want to consider Nepal at the time of the pilot in the early 1960s. Epidemic smallpox spread throughout many parts of the country and the wider region in 1963, and it revealed the fractured, limited, yet, quote, global world of smallpox, of responses to the disease. So I want to suggest that this period is key to understanding what happened later. And the pilot project, despite its limitations, provided the foundation from which Nepal's first nationwide health program developed. So my talk examines epidemic smallpox in 1963 to 1964, which was Nepal's last major epidemic. It's missing in the official record. And secondly, the WHO project Nepal 9, the smallpox control pilot project. Part of my conclusion will actually see more of an introduction to Nepal, but I don't want to put it at the beginning. The difficulties of working in Nepal are usually given to explain why things don't work. But smallpox was eradicated despite these challenges. Much of the writing of Nepal's history focuses on the Kathmandu Valley. But for the epidemic, we can at least look at 2 other areas. In both, non-expert foreigners were involved in vaccination activities. Both are almost invisible in official records, but we know about them mainly because these foreigners wrote about them. So my title slide was a picture of the highest mountain in the world. The lure of climbing Mount Everest brought climbers, but also, unexpectedly, smallpox. The second area is Lamjung district in central Nepal, where there were 2 US Peace Corps volunteers. Now this map, although it's later, but it does show the valleys of the Mount Everest area, which is what I want to talk about. And you can see Nepal's position between China and India in the corner. Now, with the Everest area epidemic that I want to talk about, the timeline is key. It's really important because what happens, it's 2 weeks. It takes 2 weeks to walk from Kathmandu to the Mount Everest area. And that, in the development of smallpox, is a key, is that important time. So we have a young Sherpa who goes to Kathmandu looking for expedition work as a porter. He becomes infected with smallpox, but the symptoms will appear later. We know from the accounts on the 20th of February, the American Mount Everest expedition departs Kathmandu, sets off on its 2-week walk. 6th of March, the young Sherpa is diagnosed with smallpox near Namche Bazaar, one of the villages on the map. Now, a few days later, 12th of March, New Zealander Sir Edmund Hillary's expedition leaves Kathmandu. 26th of March meets its first case of smallpox near another village in the area, Lukla. So, and from then, epidemic spreads along these narrow valleys to the villages, and that's what leads to the expedition's vaccination activities. They set out to vaccinate. So I'll just go back. So in the end, they vaccinate about 7,000 people, probably double the immediate area, and expands into the surrounding villages. And they know of about 25 deaths. I've got little really about numbers because in the context of Nepal, numbers actually don't mean anything, and they probably grossly underestimate what is actually happening. Now, in this episode, the foreigners were independent. They largely operated on their own as they wanted. They acquired vaccine from the WHO representative in Kathmandu. So all they needed was the vaccine, which allowed them then, which was delivered into the area, and they were able to start vaccinating. So that's the Everest example, and I'll come back to its significance later. The second area where we know something about, where we have foreigners involved, is the Lamjung district in central Nepal. Now, the involvement here was quite different. Don Messerschmidt and Bruce Morrison worked through the district panchayat, the local authority. Their contribution, however, is absent even from Peace Corps history of its involvement with the eradication program. They were not health volunteers, but as in the Everest area, local people asked them for help. And at this time in Nepal, there's a very limited supply of vaccine. So in their Christmas break, December 1963, they went down to Kathmandu. They went to their Peace Corps director, who took them to Dr. Edward Crippen at USAID, who took them to the government's Director of Health Services, Dr. Baidia, who agreed to give them some vaccine. They then went back to Lamjung and began vaccinating, but it was clear they didn't have enough and so sought more. Receiving no reply, Morrison walked. There was no road the several days to Kathmandu, where he obtained some vaccine and the promise of more. And during early 1964, they gave or organised nearly 23,000 vaccinations in the villages of the district. And we need to remember there were really no health services in these areas at the time. Linking these two accounts is the situation in the capital, Kathmandu. When Crippen arrived in February 1963, smallpox was present in the capital. He was to be head of USAID health activity in Nepal, and he wrote how he saw cases of smallpox in the streets. Cases and deaths in Kathmandu Valley were being reported in the International Weekly Epidemiological Record. Numbers were later revised downwards, but I think much likely to be higher. In November, the epidemic peaked. The Minister of Health asked Crippen if the US would supply American freeze-dried vaccine. Crippen approached the USAID director, who said no, but Crippen managed to get Wyeth Pharmaceuticals in the US to donate, and so USAID agreed to support. Crippen later secured further freeze-dried vaccine. This greatly increased the amount of vaccine available in Nepal, which did not produce its own vaccine. It never did. Some of that vaccine went to Lamjung. The highest number of cases was reported in the town of Timi in the pilot project area, but the vaccination program had been concentrating on the main towns in the valley and so had not reached Timi yet. The Director of Health Services sent Dr. Ram Bajra Adiga to head the government response, and a paper he later wrote provides a very rare glimpse into Nepalese responses, but limited time today does not allow me to go into this. The epidemic was brought under control and pilot project staff continued their vaccination program. No WHO staff were present at the time of the epidemic. So that leads me now on to WHO Project Nepal 9, the smallpox control pilot project. Cooperation and involvement with WHO through its Southeast Asia regional office offered a strategy for Nepal with its limited resources towards achieving its own goals for better health services, which were, as I've mentioned, very limited at this time. In 1969, the CERO's proposed programme and estimates and budgetary estimates for 1961 include support for a smallpox control pilot project. In August 1961, a plan of operations for a 3-year project to start early in 1962 is signed. This is to take place in the Kathmandu Valley. Now, the project was going to be located in the Department of Health Services, but was separate from the government's immunisation services. And importantly, there were refrigerators for vaccine storage. I'll come back to this point in the conclusion. And as I say, the pilot importantly used freeze-dried vaccine. And there's some debate around exactly when this came, but the reports all say freeze-dried vaccine. The project would last for 3 years and had 2 aims: to build, quote, a nucleus of smallpox vaccination activities in the 3 municipalities of Kathmandu Valley, and then of, quote, of expanding the smallpox control campaign as and when possible to other areas. This was the most populous part of the country. Now, this plan clearly indicates that the intention was that the pilot would be the basis for future activities. So whatever was thought of, it was going to be the basis. It was not going to be something new. Now, the first task was actually getting started. Now, it sounds probably obvious to make that point, but not in Nepal. Outsiders constantly underestimated the lack of everything and overestimated targets which were then not met. Annual CERO visits were made and many issues identified, but the key message that came out each time was dissatisfaction that despite the overall large number of vaccinations and revaccinations in relation to the population, the number of vaccinations per vaccinator per day was poor. Immunological coverage was too low to achieve control. In 1964 visit, WHO Medical Officer Dr. Vishnayakov learned from the Director of Health Services that plans were already underway to extend the program to start in mid-1965. The Nepalese government were taking the initiative, not zero. Vishnakov also wrote the evaluation report. There were positives, such as having sufficient and appropriate vaccine, and the vaccinators' techniques were good. But other messages regarding the level of immunity remained the same. Smallpox in 3 years had not been controlled in this pilot project area. So what next? In August 1966, Dr. David Yaram visited from Zero to draw up a plan for eradication. And the general principles were to be countrywide eradication of smallpox, the division of the country into 7 areas, each with 2 zones, and separating the activities in line with language of the intensified worldwide program into 3 phases: preparatory, attack, maintenance. He allowed for the, quote, slow development of supporting health services throughout the country. Now, previously entitled the Smallpox Control Pilot Project, the revised plan of operation was for smallpox eradication and control of other communicable disease in Nepal. So note the title was not just about smallpox, and was signed by the government and WHO in November, superseding the previous pilot project and its addendum. Now, before I conclude, I want to finish with mentioning a 1965 vaccination initiative that Yaram was aware of, the locally initiated and organised eradication programme for 2 districts in the Kosi zone down in the Terai near India. Now, importantly, the vaccinator rates in this project achieved were much higher than the pilot project. It had wide community support. District medical staff worked with the panchayat and used people locally trusted as vaccinators. And it organised their training and payment. So it showed that it was possible to do. So what can we conclude from these early years before the intensified programme? So first of all, smallpox could spread into the mountains despite what the official history suggests. We already have a global, and I put that in quotes because what does global mean, world of smallpox in Nepal in the early 1960s. WHO was a part of that, but we have Americans, New Zealanders, and various sort of others, all involved in different ways. We have, with those initiatives in the Everest area and Lamjung areas, we have locally valued, but the limited impact of foreigners. One foreigner in the mountains and valleys of Nepal cannot do very much. So a top-down program bringing in outside experts is not going to work. The Nepalese, right from the start, have a desire for freeze-dried vaccine. They knew it was better suited to their conditions, and that was what was used during the pilot. Very different views about the pilot. The pilot was, in fact, the largest communicable disease program then in Nepal, despite its low coverage. So it's not surprising the government had a different view of it from WHO. But as I just mentioned, another local initiative in 1965 showed how it could be much better. Now, there were many challenges, and this is what these early years highlighted. And as I said at the beginning, if I started to introduce Nepal and its challenges at the beginning, we'd never really sort of get anywhere. They just seemed overwhelming. But what these early initiatives and things show is that, yes, it highlighted challenges, but it also offered ways forward and around them, and the later success was built on these. Now, a photo in the official history has a caption about difficult roads. I think a more accurate caption would reflect that Nepal had almost no roads, and most of the population could not be reached with a vehicle or even a bike you were going to have to walk. So Morrison walked to Kathmandu, but not only because there was no road, but also because for a phone call to get through from where he was, from where they were in to Kathmandu, was going to require going through 14 different operators. So messages just weren't going to get through. You can't do the reporting, the surveillance and things with these kinds of limited infrastructure. Throughout the whole campaign, vaccine storage was an issue because of the lack of refrigeration throughout most of the country. There were no refrigerators. So all these basic things, and this is why I say outsiders keep overestimating what they could do and underestimating what the situation was in Nepal. The vaccination came to be preferred in the winter months, partly because in the summer, the summer monsoon, the many rivers that divided the country flooded and prevented access. You could not get to different parts of the country. So success was going to have to come, so either overcoming or going round these challenges. It was going to have to be a program coming from below. And this is why these early years are so important. Nepal eradicated smallpox despite these challenges because the Nepalese and Sero learned to work around or overcome them. And so, as I say, this is why these early years are so important. Finally, I'd like to thank the many people who, in Nepal and elsewhere, who are helping me to make Nepal's story visible. That whole Everest area epidemic is just, it's not there, but there are records we are piecing together a lot of that story. And it was not known at the time of the later program. So thank you if Don and Bruce are in any way listening, and also to Professor Hamang Dixit for his help with the Marang and Sansari district initiative. Thank you.
Good afternoon. My name is Carlos Campani, and as Sanjay introduced me, I'm a Brazilian physician, and I'm going to talk about the creation and expansion of the Brazilian program to eradicate smallpox. I will run this presentation in a timeline format, so I will tell the history of smallpox in Brazil, and of course that I will focus on the 50s and early 60s to understand how Brazil was able to eradicate the disease in 1971. We had the last case. So many, not to say most of the books that tell us the story of smallpox eradication will tell us a story that began in 1967 onwards, when the so-called the intensified phase began. But I would say that, especially from a public health perspective, if we rely on these accounts, we must have a quite simplistic, rather narrow narrative. And we must risking to ignore two main important facts. The first of them, of this, would be how a disease that was not, in many countries, and Brazil was one of them, that was not a health priority, how this disease accomplished to have so much political support, so much political commitment, and consequently financial resource to be invested and eventually eradicated. We would lose this path, the process. And also, most relevantly maybe, we would lose also the perspective of how the scientific evidence about the methodology, about the tools, the strategies required to eradicate smallpox was constructed to support the decision in 1966 when countries decided to sponsor the worldwide program. So I hope that at the end of this presentation, at least in Brazil, this will be made clear. So in the beginning, the smallpox was introduced in Brazil in the 16th century by the Portuguese colonizers, and the vaccine was introduced in 1804. The pattern during the 19th century and the beginning of the 20th century was an outbreak, especially in the big urban centers, in the ports of Rio de Janeiro and Salvador in Bahia, an outbreak every 3 to 6 years. And that was important because it disrupted the commerce. Following a pattern in Europe, in North America, every disease that disrupted international commerce was a priority for public health. So smallpox was a priority in Brazil in the first decade of the 20th century. In 1900, the foundation of Federal Serum Therapeutic Institute in Rio de Janeiro started to produce the smallpox vaccine in Brazil, which is now recognized known as the Oswaldo Cruz Institute. And laws were made to make vaccination an obligation. So compulsory vaccination was instituted to guarantee that the whole population was vaccinated and the disease was get into control. Curiosity, this led to the most recognized organized hesitance movement against vaccination in Brazil in 1904, which was called the Vaccine Revolt. But actually, the vaccine case here was only the last drop in the ocean. Many different sectors in the Brazilian society were complaining about different subjects, as the monarchists wanted the king to return, the Republicans were complaining about low salaries, and the obligation to get vaccinated was the reason to gather all the revolters, and the vaccine revolt happened. But in the first decades, through health education programs, sanitation reform, this hesitance was actually reduced to and ended, and the population supported the efforts to mass vaccination campaigns in Brazil, and the consequences that the disease was getting under control in the first decade. So that led into the next. During the first half of the 20th century, smallpox gradually lost importance in Brazil. Probably mainly because of two reasons. First of all, the disease was not a priority anymore. Other diseases like malaria, yellow fever were in the top positions in the rank of public health institutions in Brazil. And the work of the Rockefeller Foundation in Brazil contributed to smallpox lose importance and malaria and yellow fever gain importance. But also what we call the epidemiological change play an important role. Before the 20s and 30s, the main form of the disease was the variola major, which had a mortality rate around 20 to 30%. But after the 1930s, the variola minor was the predominant type of the disease, which, as the name says, it's a minor disease, really mild disease. 1 or 2 days of low fever, you have a rash, but most importantly, workers were able to go to work, and children were able to continue to go to school because it was a mild disease. And this led, as the Brazilian historian Gilberto Hockman claimed, this led to a kind of a social coexistence where not only the society but the politicians accepted the disease as a minor children disease and not a priority anymore, not something that we should be worried about. And following that we have two evidence for this lose of importance. In 1920, when the first National Department of Public Health was instituted, many diseases caught a specific department, sub-department. Smallpox don't. And the control was the responsibility was changed from the federal government to small local agencies. And during the 30s and the 50s, this attitude didn't change. We experienced many changes in the type of governments in Brazil, but the attitude was the same. One proof is that in 1952, in the official National Service of Health Education smallpox campaign, the government blamed the population for the sporadic outbreaks because the vaccine was available, it was compulsory, but still people didn't vaccinate because they didn't want. The problem here is that the service that existed only in the urban centers. So the people who lived in the rural areas didn't have access to vaccination. And at that time, most of the Brazilian population lived in the rural area. So now I'll give a break in Brazil. I'm going to take a look at the continent, a continental perspective, because it's important to understand what happened especially in South America, to understand some decisions that the Brazilian government made later. So, in fact, in 1950, the PAHO, the Pan American Health Organization, which is the regional office for WHO, launched a continental smallpox eradication program. Not too much resources for that, not too much support, mainly based on stimulating countries to start to produce the new freeze-dried, high-quality vaccine. And the national government was still responsible to carry on the program and the mass vaccination campaigns. Ecuador was a successful case. It started their program in 1958, and they were one of those countries that during the first phase, from 1958 to 66, it was able to successfully eradicate smallpox. But some lessons were learned in other countries. Colombia was an interesting case. They started the program in 1955, but actually after 5 years vaccinating more than 80%, roughly 90% of the population, they still have cases because they left pockets of people unvaccinated, susceptible population. And that was enough for the smallpox virus to circulate in Colombia, and Colombia still had cases of smallpox, even after a reasonably well carried on program. Peru and Bolivia also highlighted the importance of a maintenance phase. Both started a project, Peru in 1915, Bolivia in 1958, and they were able to eliminate the circulation of the virus initially in their countries, but without a maintenance phase, populations, especially newborns, immigrants, they started to accumulate, and pockets of susceptible people accumulated, and cases were already actually restarted in these countries, especially being imported from Brazil. And Venezuela, Paraguay, and Argentina, although they were not successfully eradicated smallpox, but they gave PAHO a great and important message. Virus don't respect political borders. They don't need a passport. So the virus came from Brazil and constantly infected people in Argentina, Venezuela, in the borders. So that was an important tip for the Pan American Health Organization, when 1965 to 1967, when a new program started in the American continent with all countries aboard, every country signed an agreement, because it was not only Brazil the problem, because the virus could be imported at any time. So all the countries needed to be vaccinated, the people, at the same time. So I just said that in 1950, the PAHO launched a continental program, and 1958, WHO launched a worldwide program. And how the Brazilian government responded to both proposals? Well, quite differently in reality. For the 1950 program for the PAHO, nothing actually happened. Brazil government maintained the inertia. Control of the vaccination programs is still decentralized in small local agencies. One good evidence was the 1956 JK speech. JK is our JK, Juscelino Kubitschek, important Brazilian president, that he claimed that the mass disease must be prioritized. And what he meant by mass disease: tuberculosis, malaria, not smallpox. Although government was neglecting the disease, Brazil was not with their arms crossed at all. Some specialists, for example, some specialists went to the continental seminar on smallpox vaccine in Peru in 1956 also. But 58 was different. JK accepted the proposal made by the Soviets, and for the first time in the 20th century, smallpox was mentioned by a Brazilian president on a speech, and he claimed that smallpox was eradicable, and new official health policies start. First of all, he accepted WHO and PAHO assistance, especially regarding the quality and production of the Brazilian vaccine, and it changed the hierarchy and how the mass vaccination and vaccination on smallpox was carried out. He took the power from local small agents and centralized the decisions into the federal government. But does that mean that Brazil started in 1958 a program to eradicate smallpox? The answer is no. Brazil lacked the resources needed, especially the vaccine, a high-quality freeze-dried vaccine. Brazil lacked also a cadre of public health officials specialized in smallpox. Smallpox was neglected for a long time. Most public health officials from Brazil, they were worried about malaria and yellow fever, and we lacked, of course, the structure, the basic health structure to promote mass vaccination in the entire population. So all the steps during 58 to 61 were focused on vaccine, to produce public health officials experienced in the disease, and to strengthen the basic health system. 1959, for the first time in many years in the Brazilian Congress of Hygiene, public health officials started to talk about smallpox, and claiming that it was a eradicable disease. One of the officials said one phrase that became famous at the time, that each country suffers from the smallpox it deserves. He was criticizing the negligence, how the Brazilian governments ignored the disease in the last decades. And one turning point was in 1961, in the Charter of Punta del Este in Uruguay. Parts of the Alliance for Progress movement in the American continent, that Brazil officially started a policy claiming that if a disease is eradicable, the government will make all the efforts necessary to eradicate this disease. He was referring to malaria and smallpox. So during this time, although it lacked all the resources, small pilot projects, especially in rural areas and in the borders, were introduced, started. But it's important to understand that during this period, only glycerinated vaccine was used in Brazil. And at that time, population in Brazil was around 75 million people. So the number of people vaccinated was really small, but it was a start to understand the best process to start mass vaccination campaigns. So with the political support, now with the freeze-dried vaccine being produced in the Fiocruz in Rio de Janeiro. So in January 1962, the government launched the first program specifically targeting smallpox. Was the national campaign against smallpox. Notice that there was not control or eradication in the title of the program. And many Brazilian historians also, they claim that this program was not a program to eradicate smallpox, was more related to smallpox control. But if you look at the goal for the government, they aim to vaccinate 80% of the population in 5 years. And at that time, that was exactly what WHO was saying to the countries. If you do that, in 5 years, you vaccinate 80% of your population, you will eradicate smallpox. So I would argue that this program was indeed made to eradicate smallpox. However, the responsible for the program was not someone specialized in smallpox, because we didn't have at the time. It was coordinated by the National Service of Health Education, and the program was decentralized. Actually, the federal government only provided the vaccine. The responsibility to organize and carry out all the mass vaccination campaigns was in the states, 26 different states in Brazil. So, as 26 different programs in one major program, lots of heterogeneity actually happened. Some places worked with fixed posts, other states with the methodology of house by house, with mobile teams. So lots of heterogeneity and two big problems. One, the program was heavily underfunded. It started in January 62, but in the second semester of 62 and in the first semester of 63, no funds at all. So no one was vaccinated. So lots of difficulties with funding. And most importantly, Brazil experienced at that time lots of political instability, many changes in commands. So in fact, the program was not successful. And because of this frequent political instability, in 1964, a military coup deposed the elected government. It's not my aim here, my purpose, to talk about why it happened, but in fact, the result of the military coup was, it can be assumed that was beneficial for the program because of 3 points. The first, as every dictatorial power, it centralized responsibility. So it took responsibility from the states, and everything now, from now on, would be decided in the federal sphere. So, and this, at that time, when Brazil didn't have a strong basic health system structure, was the ideal scenario for an eradication program. And also the government sought for international and national legitimacy. And how did they do that? Internationally, they started to work closely with international organizations, especially WHO and PAHO. And nationally, they sought for programs that could have an impact nationally, and they could differentiate them from the older regime. So they saw in the smallpox eradication a good opportunity to ally themselves with international organizations and with the people from Brazil seeking legitimation for their military coup. As they started to work closely with international organizations, and especially with the United States, in January 1965, I would say the watershed process happened in Brazil, which was the value of scientific evidence that started to put smallpox eradication in something really tangible, something that could happen. Two main problems in Brazil at that time. First, what was the methodology to carry on mass vaccination campaigns? It was basically responsibility from the states, lots of heterogeneity, so it was a question to be answered. And second of all, and probably most important, funds. Brazil was not a rich country at that time, so the program needed to be cheaper. And this piece of work was really welcomed at that time and supported, I would say even guarantee the political support that a program like smallpox eradication needed. So the research compared two different strategies, one using jet injectors, the other one using multipuncture technique, house by house, the jet injector in a fixed vaccination post. And the results show that the first jet injector in the fixed vaccination post was much more efficient than the second. And most importantly, the cost for those was 7 times lower than the former strategy that the government was using. So this was a new strategy for Brazil. It showed a faster and a cheaper way to progress with vaccination and eventually eradication. Just to summarize the former program, so roughly 24 million vaccinations in the Brazilian population, which accounted for 19 million, around 66. So you can see that in the best case, around roughly 40% of the population in the Northeast and the Southeast region were vaccinated. The negative aspects, I already talked about it. It was decentralized, many chains in command, lots of political instability, and basically, most importantly, lack of proper fund, but it also had specific positive aspects. The first of it set an anti-smallpox drive, not only in the population that started to want to get vaccinated, but they formed public health officials experienced in smallpox, young public health officials that started their career working on smallpox. And this is really important in countries like Brazil, and most importantly, the political support that was accomplished, especially with the scientific evidence that I showed before. That led to, in November '65, the military government wanted to break any chains with the former program. So in 1965, a written agreement was signed between PAHO and Brazil. As I said, every South American country signed a written agreement to eradicate smallpox with PAHO. And I look at every agreement, and in every country, the main purpose to launch the smallpox eradication program was because of the disease that struck their population. The Brazilian agreement, although Brazil was the most important country in the region, having cases of smallpox and eventually exporting the virus, in the Brazilian agreement, it was all about Brazil being an international threat. It was like the Brazilian government was saying, okay, so to do what your countries, every country want, I will start a smallpox eradication program in Brazil. That was something that the government wanted, international legitimacy. So that's why I'm claiming that for the smallpox eradication program, the military coup was advanced the purpose of this program. So basically, the program started in 1966. The characteristics was centralized. Now the program was run by the health ministry, Brazilian health ministry. Goal to aim to vaccinate 90% of the population, and the strategy was based on mass vaccination campaigns using the jet injectors. The whole program was planned and organized by Brazilian public health officials and the government. I would say that WHO and PAHO was partial blind about what was going on in Brazil, and we had a series of letters exchanged in 65 and 66, weeks before the launch of the program, from letters exchanged between PAHO officials and WHO officials in Geneva. They were surprised what was going on in Brazil. They didn't know who was the chief of the program. And once the deep-seat official in Geneva eventually claimed that WHO and PAHO should start to support individual states in Brazil to accomplish eradication. And that was when one of the PAHO officials in Washington, they said they understand how the Brazilian system works, how the federative pact works, and they say, no, this can't be done. Brazil is different than other countries like Pakistan. When this strategy happened in the past, not regarding smallpox, other disease, but also it happened in the past. So, but in Brazil, it can't be done. Every contact must be done with Brasilia, with the central government. So when WHO officials joined, 3 officials joined the program already started in 67. And the role of WHO was basically technical advisory support and funding, especially donating cars for mobile teams and the jet injector. Just to conclude, I always, when I studied smallpox eradication program, I always like to think about a comparison to marriage. When you asked about how long have you been married, every one of us will say from the date that we said yes. But I would argue that that's wrong. We should not do that anymore. Because a marriage, a relationship started when you first start to date your boyfriend or your girlfriend. The whole history before you get married is important for your relationship. And like that, when we study the smallpox eradication program, we can't just analyze what happened from 67 on. Because when we do that, we lose all the story about how political support, and I just said that in Brazil, it was really different than other countries. Every country, every nation had their particularity. So we lose how that happened, and we lose how the evidence was constructed, built on the ground to support the decisions, the political decision to invest, to sponsor the program. So the main points that I would like to highlight to end, the set of an anti-smallpox drive was extremely important during this first phase in the 50s and the early 60s. National particularities must be kept in mind when we analyze each country. It's different. Development in fields is extremely important. Research and development was fundamental to accomplish the support that was necessary, and also strengthening the basic health services and the main legacy that led to Brazil, especially in the vaccination program and in surveillance also. I think that would be all. Thank you.
Good afternoon. I would like to thank Professor Sanjay Bhattacharya, colleagues at CGHH, and the University of York, whose support has made my fellowship experience truly incredible. I'm grateful to the Commonwealth Trust for the award and my employers in Mumbai, who enabled leave so that I could avail this fellowship. Finally, I thank my co-panelists, Sue, Lou, and Carlos, for discussions that preceded this panel today and hopefully will follow much after we close. So I have for you here the words of two famous participants in the worldwide program as well as the Indian program. I quote, "After the 1966 World Health Assembly voted to create a global smallpox eradication program, India did not immediately set up a WHO-assisted campaign, as nearly all the other 34 countries had done. But in that year, India did make a substantial contribution to world smallpox. It was a very big number in that year. Still, India counted on its large army of trained health workers and the state NSCP programs to break the back of smallpox without external assistance." We have Henderson, who says, "The government insisted that national staff, now with more than 5 years' experience, could learn nothing from the WHO advisors. WHO advisors were not allowed to move out of the country without permission from the government as well, though they were demanding to help and claiming to help." Both these participants have written extensively about India, and here in their personal memoirs, they sound clearly exasperated by Indian arrogance. In 1967, there were 85,000 recorded cases, the highest in a decade. So from 57 to 67, this was a very high number, and this was about 35% of the world's smallpox. It was well after India had officially begun its global program in 1962. The government was far from achieving its ambition of smallpox eradication, and this has been declared in several reports since. But as we all know, India eventually did eradicate smallpox, and that indeed is a remarkable story, but not the subject of my talk today. I will be commenting on the decade of the 1960s. Paraphrasing the historian Paul Greenough, who has written about certain aspects of the Indian program, I believe there are enough reasons for stirring up the embers of the early Indian eradication program. So I'm going to outline key features of the national program, particularly commenting on the background, the mass vaccination strategy that was adopted, and explain how the Indian experience became central to the early evolution of global strategy. In the course of this talk, it will become evident that the global program itself was rapidly shifting strategy and drawing on experiences from the field. I will close with an illustration of the importance of recognizing local attitudes, which is the overall theme of our panel today. This I will show through the Indian response to the introduction of the bifurcated needle, which itself was presented as a panacea to the problem of technique, speed, and optimization of vaccine usage. And then I will make a few observations. Just to set the context, India has a large number of religious communities, majority of them Hindus, for whom smallpox was seen as a visitation by the goddess. Shitala, the cool one or the mild one, the gentle one, commonly referred to as Mata, which means mother, in the belief that this goddess has the power to cool the fever of smallpox and to prevent it from becoming fatal and killing, especially children. Shitala is worshipped in large parts of northern India, western India, and eastern India. But in western India, she is not exclusively associated with smallpox. She has other functions as well. In South India, we have the deity Mariamman. So smallpox could result from the wrath of the goddess if you are displeased her in some way, but it There was another explanation. It could also be a result of an imbalance of heat and cold, which comes from traditional Ayurvedic understanding of the body system, but also in folk medicine. Now, this assumes importance because traditional ideas about the causation, prevention, and treatment of the disease reflect cultural and metaphysical setting in which the disease appeared, and also provides the backdrop against which the eradication program unfolded. The World Health Issue declaring the eradication of smallpox in May 1980, for example, had an important article saying the goddess defied, which was obviously referring to the Indian goddess of smallpox who was defied, and smallpox was eradicated. So this is quite interesting. So what's the background of the disease in India? It's called chechak in most medical texts, and this was the word that was used by public health workers, though usually people would say that they were visited by the goddess, Mata Ana, and which is what even I have heard and used for both chickenpox and smallpox. So interestingly, chickenpox was usually called as Choti Mata, which means a smaller goddess, and smallpox, because it was more fatal, it was called as Badi Mata. India is an endemic region. It's home to variola major, a deadly form which kills about 30% of those affected, and maims and blinds most people who are affected by it. If you survive, then you survive for life. There was this anecdotal stories that when people were married off, they would look for grooms who had pockmarks so that you know that this person is not going to die and you're not going to be widowed. So Indians traditionally practice variolation, a characteristic which was shared with the Chinese, though the practice has eroded due to prohibitory legislation over time. India has had epidemics every 5 years. It is seasonal. It peaks between December and May, and therefore the heat, which is and subsides during monsoons. The virus is quite contagious, though various studies have pointed out that the most likely source of infection is contact with the patient in the early phase of the disease, and primarily through direct droplet transmission. Along with plague and cholera, smallpox cases were recorded in colonial public health reports through the 20th century. The major epidemic years in independent India were 51, 58, 63, 67 and 1974. So it comes in these 4 or 5 year cycles. The few indigenous cases that were seen in 1975, and finally India was proclaimed a non-endemic country on 5th July 1975. A few words about health planning in India. In the 1960s, we had a population of about 400 million people, 16 states. Now we have 29. Now it's important because each state had its own health ministry and related departments and officials. So though there was a central ministry and international agreements, etc., were negotiated at the central level, actual implementation of policy happened at the various states level. And so therefore you see for every national program that was implemented, unless and until it was centrally sponsored, there was a considerable amount of variation in the program. Why was the National Smallpox Eradication Program launched? There was a massive outbreak of cholera and smallpox in 1958. An expert committee of the Indian Council of Medical Research was set up in 1959. Pilot projects in one district of each state and in Delhi were conducted to ascertain the problems on the field, and an important discovery, apart from administrative bottlenecks, which are to be assumed, was the faulty technique and inadequate training of vaccinators. So a special note on instruction for vaccinators was prepared, standardizing the technique, standardizing the number of insertions, how the vaccine was to be given and circulated. But as we will see, standardization remained an exception rather than the norm. These pilots had used liquid vaccine produced in India, except one state, Orissa, which had got freeze-dried vaccine from Netherlands. Though the NSCP was finally launched with freeze-dried vaccine donated by the Soviet Union, and Professor Sanjay Bhattacharya has shown the complex negotiations that preceded this switch even to begin with a liquid vaccine. What was the strategy? The essence of the strategy called for a specially recruited team to move systematically from house to house and from village to village throughout a district in an effort to vaccinate or revaccinate not less than 80% of the population. With this proportion vaccinated, it was expected that a sufficient number of persons would be immune so that smallpox transmission would terminate spontaneously. So this was the magical 80%. The vaccination team was preceded by enumerators who listed in a large multi-page register the name of each person along with his age, address, as well as previous history of vaccination or smallpox. One register was compiled for each village or defined area in a city and was intended to be used for the next 20 years. So this register had larger public health functions as well. After enumeration had been completed, the register was given to the vaccination team, which then endeavored to vaccinate all those people who were listed. This register was then given to an inspector who was to check each vaccinee to ensure that the vaccination had been successful. Because as most of you would know, simply giving a vaccine doesn't mean that that it's a take. It may have not really produced the necessary reaction. Subsequently, local health unit vaccinators, there was one for every 50 to 70,000 persons, were assigned the responsibility to vaccinate those missed out in the mass campaign, and which was called mopping up. And I kept seeing this word mopping up several times, and I kept wondering, what is this mopping up that is being referred to? And this mopping up campaign was essential because it would be people who just were not found when somebody went and knocked on their doors. It could be mobile population. It could be people who were not with a permanent residential address, living on the streets, and so on and so forth. So finally, mopping up was also important. And finally, there was this injunction to revaccinate everyone every 5 years and vaccinate contacts when smallpox were discovered. Health education was an important part of the program, and enumerators were also expected to talk about the importance of vaccination, considering the traditional beliefs about the disease and the fact that the disease itself was seen as a visitation by the goddess. So why would you want to vaccinate and not welcome the goddess? Now, a very important observation that was made in the pilots was that the resistance was not due to religious beliefs. An important observation was made that it was the faulty technique and the use of a contraption which is unique to India, and you'll hear more about this later, which was called rotary lancet. As was standard practice, 80% of all sections of the population were to be vaccinated, and after 3 years, the maintenance phase would begin in March 1965, when it was hoped that the NSCP would be absorbed into the local health sector network. So, as you can see, these vaccinators were trained. They were trained for about 6 weeks, and each one had to vaccinate about 100, had to have 100 vaccinations every day. This was a centrally aided program with a considerable amount of investment by the central government. What is very interesting is that all of this was achieved without any legislation. So if you look at the records, a lot of stress is paid by the people actually on the field, clamoring for legislation, but the government always desisted. They never, brought out compulsory legislation. There was some variation. There were some states which had legislation, but in any case, it was not ever enforced. So this is very interesting and a very unique aspect of the program. There was an important outbreak in Delhi in the winter of 1963, and this was while the campaign was on. So there was a major outbreak and everybody was taken aback. Why is there an outbreak when the campaign is on and people are claiming that 80% vaccination has been achieved? Following this, there was an independent assessment done. And following this independent assessment, there were independent assessments done in various other districts. And a manual was created where people who were vaccinating could also do assessment and evaluation. And what was an important finding out of this? It was realized that there was a discrepancy between recorded vaccinations and actually immunized people. And thus, the target was now changed from 80% to 100% mass vaccination. Now, the director of the NSEP, Dr. Lal, made a presentation of his findings before the first expert committee on smallpox that met in Geneva. So, this one. So, Lal makes all the presentations of all these assessments that he has done in this expert committee. The report sets a target. It's very important to note this. The report sets a target, and this is this expert committee, which sets a target of covering 100% of the population in the attack phase. In all probability, drawing from the Indian assessments. And this fact has also been recorded in the WHO official history, the big red book that all of us keep reading. Though mass vaccination had been elaborated upon, in all fairness, this document also mentioned controlling the spread of outbreaks through ring vaccination, meaning if there's an outbreak, you vaccinate people around the person who's been affected, and therefore you stop the transmission of the disease. The mention of family registers and laudatory references to independent appraisals of the program in different parts of India as a template for national control programs in other countries indicated the crucial role played by Indians in global experiments with designing similar programs. Concurrent evaluation in India, which means while the program is on, you're still evaluating it, this was specially singled out for praise, and I've seen several notes, unpublished notes, which were published around 1964, which discuss this organization and concurrent evaluation and commend India. Finally, the report in fact suggested rechristening the national level eradication programs as national smallpox control programs, arguing that the word eradication could be applied only if you were conducting the program over a large area, say a continent or the whole world. And this brings me back to Carlos's point of this word control being used. So he is in fact arguing that though the word control was used, they were actually doing eradication because it was obviously 80%, and he's right. But there was this distinction of nomenclature that was also proposed in this report. Nonetheless, by 1965, all these program assessments, though fruitful, were also scathing and pointing out the deficiencies in the program. The focus on number of vaccinations elided the distinction between primary and revaccination, and groups such as school children were vaccinated several times over because they were easy to access, while infants were largely excluded. And this was a major drawback of the program. And finally, it was calculated that the overall vaccination coverage was around 63%, and it varied in various states. So in some states, it was less than 63, much lesser than 63, in some higher. So overall, it was 63. Meanwhile, things were, as you can see, are escalating internationally. So I'll just go back to the assessment and, yeah. So this is, the initial pilots, the 660, 61. So the first projects were conducted in these districts in each state, and these districts were chosen because they were inaccessible, difficult to go to, or remote. So they were chosen for these reasons. Then in 63, 64, these areas were assessed. And finally, and I'll come to this in a moment, these were the states. There were five independent evaluations, including Delhi, in 1967. As you can see, what is happening around 1966, the famous call is given, and thereafter things escalate really fast. A flurry of reports are published, technical documents are published, a new strategy which is called surveillance containment is also referred to, and what we have then is a new focus. And meanwhile, the Indian program was supposed to go into maintenance phase, but there were several epidemics. It's almost thrown out of gear, and this has an overall demoralizing effect on the people. While earlier evaluations, which were conducted in 63, had a handful of consultants, the 1967 joint evaluation had 8 WHO staff or foreign staff of US aid and so on and so forth, and 8 Indian staff. And finally, at this point, India had to agree now to have more than merely technical assistance for the program. So this brings us back to this anxiety that Henderson was expressing, is why is it India not accepting help? So, but in 70, there's a new agreement that is signed between WHO and India, and the first staff arrives in 1971 and then begins a new phase of the program. What is usually forgotten is that 1966-67 was a particularly harsh outbreak of famine in Bihar, and you have heart-rending images of famine-stricken as well as smallpox-stricken children. There was a severe drought in India, and not to speak of the general conditions of scarcity which were created because of a war with Pakistan. So another thing, so in this period, however, the global smallpox eradication program is progressing with certain key publications and certain things being advocated, one of these being the bifurcated needle. So it was introduced in 1968, and this was the manual. It was made of stainless steel. It was only 2 inches or 5 centimeters long with a 2-pronged fork at the end. And though the technique was multiple pressure, Henderson sort of modified it and made it into 15 punctures. What was the main advantage of this new contraption? The fact that it used less vaccine. So with one vial, you could now vaccinate 100 people instead of 25 that were being vaccinated. So this was like a 4-fold saving of the vaccine. And that was one of the main reasons why it was being pushed. The other thing being the needle itself was quite cheap. You could get about 5,000, you could get it 1,000 needles in $5. And this brought down the costs of vaccination considerably. So I'll just share with you the various techniques through history. L is the bifurcated needle. So you see how it sort of, this is, and the other thing about the smallpox vaccination is it should be in the, it should not penetrate very deep into the layers of the skin. So this was very important, and therefore most of these techniques sort of, so you had to strike a balance between not being too superficial and not penetrating too deep. This is the rotary lancet, which we'll come to in a minute, and which was very popular in India. There is something which is called as a simple scratch, which is how you could just scratch. So there were different ways. You could either put the vaccine and scratch the vaccine into your skin. So there were different techniques. There was also this idea of how many insertions that you make. Do you just put one insertion? So that means you give the vaccine only in one spot of the skin, or do you give 2 insertions? And that would determine how potent the vaccine would be and how much of immunity would be created. This is the rotary lancet, which was extremely popular in India. For reasons not fully explained, it was very popular. In fact, there is a reference to something called as the Bombay model, which came up in 1935, and it was used in the Indian subcontinent, also in Pakistan, and subject of much scorn and ridicule, again by both Henderson and Brilliant in their account. It caused painful arms, and most importantly, it wasted vaccine. But Henderson was not the only one who had tried to turn the Indian vaccinator away from its use. The assessments which were done, and I mentioned them in 1963, especially in Mysore and Palghat, indicated that the vaccination technique with rotary lancet and freeze-dried vaccine was causing painful arms, leading to resistance, and they pleaded with the authorities that new tests be conducted and move be made away from the rotary lancet to using a pin or a pointed nib with the multiple pressure technique or the linear scratch technique to reduce trauma. They urged conducting studies, but a circular was released in 1964 conveying that the Smallpox Workers' Conference had decided that the rotary lancet would continue. Why was that? because it had been used for decades, and I quote, "It was not considered advisable at present to change over to linear scratch method in the midst of the eradication campaign. But it was unanimously felt that the size of the rotary lancet be standardized," unquote. So the rotary lancet was not given up, and we understand it was primarily due to pressure from the actual vaccinators who were on the field. So what happens when Henderson tries to introduce the bifurcated needle? There's always opposition again. This time both from administrative and scientific leaders. There were questions of acceptance by the public, whether using the bifurcated needle would produce takes. And the concern was primarily because of the very small amount of vaccine that would go into the needle. So it would be a very small quantum, and most of the vaccinators would say that why would this produce any kind of a take? So thus it was decided that the National Institute of Communicable Diseases in India carry out a comparative study in Delhi using both the bifurcated needle as well as the conventional rotary lancet and decide whether the bifurcated needle was good enough. Some of these studies were conducted, and finally people were convinced to switch over, though this was also not complete. I have given this example to show how the program did not develop with quick technical fixes. New technology, perceived as superior and beneficial to project outputs, was not simply transplanted in varied settings. There were local concerns and anxieties that had to be assuaged. Experiments were conducted by national authorities before they were accepted, and even here, as is candidly admitted, rather reluctantly. Attitudes and habits were greatly resilient, and people had to be persuaded through the mediation of local authorities, and many a time even permitted to continue the old practice. Though the bifurcated needle was introduced world over in 1968, in India it was not used right into the 70s. This is important to emphasize the adjustments that the WHO and global efforts had to make so that programs functioned rather than simply broke down. And finally, I would like to conclude. The official SEP report acknowledges that following the national program, millions had been rendered immune through vaccination, and a decrease in the true incidence of the disease would have occurred, but probably there were also better notification, so you could not see the actual decrease in incidence. There were other regional variations. The southern states were doing very well. Health education benefits were many, but most importantly, as Sanjay Bhattacharya also points out in his book, that the vaccinators or people, manpower was trained, and this eventually became important when the intensified program was launched. It is also admitted in a lot of private unpublished correspondence which I saw in the WHO archives. In many ways, mass vaccination was quite in line with the public health strategies of the time. In any case, the final verdict on surveillance containment for the final inch is also mixed. For instance, Nancy Steppen reminds us that it was not crucial for the program in Brazil or even in Upper Volta. So finally, if you look at the eradication saga only from the standpoint of WHO's global call of 1966, we are doing a great disservice to the modern smallpox story and erasing histories. Perhaps it is time to study national stories upwards rather than from the international level down. So since I had begun with a quotation or words from an American, I go back to words of another American, Fred L. Soper, the arch eradicationist, the big daddy of eradication, if you will. And what does he say in the American Public Health Association meeting in 1965? He commends the Indian program for stopping smallpox entering Europe and America in 1963-65, and he also says that the program was on its path, and if it continued, it would have led to success. Who knows? Thank you.
Godfrey, over to you now.
Okay, can you all hear me?
Yes.
Yes. Okay. Right. Hi, everybody. My name is Godfrey Sikipa. I am speaking from Harare. So first of all, let me just take this opportunity to thank colleagues at York University for facilitating my participation in today's seminar. I have to say that until I met Sanjay and Joel a few weeks ago, I was not really conscious of and aware of the importance of the history of public health. And I must confess I now have a newly found realization of the importance of that history. You know, as I listened to the four excellent presenters today, I now realize that perhaps there's been a significant deficit or deficiency in the teaching of either medicine or history in our part of the world. I have to say that both in the departments of history and department of medicine, I don't recall any concerted effort to teach the history of the public health. So I'm hoping that this realization and the interaction that we had with Sanjay and a few weeks ago will initiate some movement and hopefully support from WHO and other universities that are more advanced in this area of study. I listened to the history of smallpox. I have to confess that I had not read the history of public health, but the history of smallpox eradication. But I can say that in our part of the world, as Zimbabwe in particular, there is a chronology of smallpox starting back in the 1920s, and there were sporadic epidemics between that time and 1928 until about 1968, when it was declared eradicated in our part of the world. So my comment or my general concern in today's presentation or seminar, I would like to request and ask at the same time what might happen or what could happen to promote the documentation of public health initiatives and public health happenings. I have recently finished work on the development of a community health strategy for Zimbabwe. Just looking at what's coming out of that process, I see a situation where the involvement of communities, the inputs, and the role of communities in eradication of various communicable diseases could easily go unnoticed, undocumented, and I believe that this would be a serious deficiency or oversight for the future. So my hope is that with this realization, we will get some serious thinking, some serious actions taken to ensure that some of the goings on at the moment, especially the history of primary health care and the role that communities are now playing in eradication and just contribution to public health will be well documented and for the future. So once again, I'd like to thank your colleagues for involving me in this seminar today, and make a plea that let this be the beginning of a rich process of documentation of the history of public health. Thank you.
Thank you, Godfrey.